Welcome to the Orthopedic Indications channel, where we discuss medical education for medical sales consultants and reps. All right, what about this one? So we're going to say this is a Weber B. And this is a patient that fell a couple days ago. They come into the office complaining of lateral sided ankle pain. So if I kind of look at my see if I can pull up my drawing here. Here's the break, here's the fracture. You can see kind of extends down here to the level of the joint, so we'll call that a Weber B. And patient says that they can't really put weight on it, too painful. Swollen, bruised, a little bit of bruising on the medial side. What's your workup for something like this? Can't walk on it and still having pain.
Yeah, so you mentioned they can't walk on it, so I think that's one of the key things here. So then I'm thinking this could be unstable. Because a lot of times I think the patients who have a more stable injury, they'll be like, yeah, I've been walking on, like you said, I've been walking on it for a couple of days. I went and got it checked out. I thought it was an ankle sprain. Urgent care says it's broken, or the ER does. So this is one where, I know I would gravity stress this if they're having a lot of pain, or I would try to have them do a weight-bearing stress view. It would depend. Like after examining them, you kind of get like this, not 100, gestalt, right?
Yep.
You're really swollen, and you're like, okay, like something's going on. They said all the right words. Cannot weight bear.
Yep.
Really painful. I feel like it's out of joint or something. Like,
yep.
I would think about some instability. If they have medial pain, the studies show whether they have medial pain doesn't really correlate with a deltoid injury or not well. So, I kind of just this is when I listen to the patient and then and take it from.
Yeah, I think that's a great point. And so you mentioned this using, I think you said gravity stress. The important thing on the gravity stress is to stress it the right way.
Yes.
I've had more than I care to share of ones that get stressed the wrong way. Usually they're not from our clinic, but where you're like, it's on the that bump is on the medial side of the ankle, and it gets rotated. So, and when we were residents, I'd always just think about recreating the deformity. We talk about it helps when you do some reductions of these, because then you start to understand the way that things are moving, and it just becomes second nature. And that's part of the reason the hands-on ER work is so valuable to one's education and stuff. But here you can see they have a bump underneath the lateral side of the ankle. They're letting the foot fall away. It's opposite of the way that you would hold the foot in order to reduce this particular, say this fracture was dislocated, that you'd move it the other way. And so you can see here, it's not, I'll be honest, it's not a great stress view. It's a little bit, I don't really have a great view of the mortise there. I have a little bit better fluoro view there in the middle. That's probably more representative of what you would want to see in this particular situation. But to your point, once a lot of times you kind of get a gestalt that maybe this is okay, and I kind of think that that's kind of, in some respects, that's kind of what happened in this case, because then you see my next view, and I don't remember if it was right away, but this is the weight-bearing view. And again, to your point, don't know if they were actually able to weight bear fully load on it, but you can see looks pretty symmetric relative to the other side. Wouldn't you say? Like, is this fracture, if you look at the lateral view, it's pretty displaced. And I think the point is like you can treat these, like look at the lateral view there. It has a fair amount of displacement, but I felt like it was reasonable to treat this non-operatively in this case, unless you think otherwise. Maybe I'll have to edit this out.
No, I've treated now a few of these non-operatively. I did a similar one who, it was a recent patient, very young, like they were in their, late 20s, early 30s, and they had a little bit more displacement, but his mortise was intact. The talus was under the tibia, and it was a little wide laterally, and that's what I struggle with to do. If you go back to like the mortise view, back an X-ray there, so what if like the talus is perfectly reduced under the tibia on a weight-bearing view, but on that view where the fracture is, it's just a little bit wide. Lateral side, I don't know. I treated him non-op and he's done fine, but I'm like, well, the mortise is intact. Like the talus hasn't shifted. Like the deltoid must be intact.
Yeah, right.
And he has no view where the talus is shifted at all. So I hope it's like one of those things where like that's I think sometimes like I get more stressed about treating these non-op than operatively because I know I can fix this,
Yeah.
but there's also risk to surgery, and God forbid someone gets a risk on a maybe poorly, I mean, has a complication on a poorly indicated surgery, then that's much worse, I think.
Two thoughts. One is sometimes I will manually stress these because the gravity stress, the ones that you kind of think are like, let's just say it opened up under that gravity stress, you really have to pay attention to what the foot is doing, because if the foot is plantar flexed a little bit, it opens that space up a little bit. And I'll get a number of referrals from some of my partners, and they're like, oh, they have an unstable stress view, and you look at it and you're like, well, it's really plantar flex, and they're like, I'm like walking on it, and so they kind of come to you for surgery, and then they come out and you're like, I don't think you need to fix this. Yeah. So really look at the stress view, and if they've been doing that where you're trying to like you're trying to think, well, this doesn't make sense, get a weight bearing view like this, and I think you'll answer a lot of questions.
Yeah, so what do you do though if that lateral malleolus distally is a little bit displaced laterally, maybe just a little bit more than what you have there?
Same thing you do. I typically treat those non-operatively.
Yeah.
Can I say absolutely everyone? No, not really. And the other thing I was thinking is sometimes I've done manual stress thinking that if I get on there and really push on it, I can make it positive, or maybe they just didn't like hold it right.
Yeah.
And most of the time, I'll be darned if the gravity stress does it. It's good. It's pretty spot on.
I did the gravity stress on that guy, and I'm like, it looks the same. I was like, okay, I guess he bought non-op.
Yeah.
Like I was trying to prove he would be unstable.
That's exactly right. Yep. And I have
prove it.
Fully done where ones where maybe it was on the fence and I ended up fixing them because of that, because they're young and I'm like worried about long-term risk of arthritis, and it opens up enough, and I was like, I probably should. And you stress them at the time of surgery because you're like, I really want to see how unstable this is, and sometimes it's a little shocking how it's actually okay. And so I think there's some over treating. I know that we worry about arthritis with this, and that's the hard thing that I think we have that we struggle with is not necessarily the short term. I think they'll heal fine, but it's the long term effects of that joint, because we do know that can play a role with these patients.
Absolutely.
All right, so I guess this is another case here. This is a little higher. We'll call this more of a Weber C, and these are the initial views. These are non-weight bearing X-rays, and kind of my question on this. We talked about the medial malleolus, the lateral malleolus, and if any of these remain intact, usually the mortise is going to be stable, But what's your number? We talked a little bit about gravity stress and looking at the medial clear space. Like, is it 4 or 5? Is it 6? Like, what? This is that kid's stress view. So, do you think this is unstable in this particular situation?
So, I'm going to say yes, and not because of the 6 millimeters, or at least I'm highly suspicious, because what I go by for, when I was a resident, they would talk about 4 millimeters or so, but that's hard for me to measure, and these are not necessarily, unless you have some type of standard on the X-ray to know exactly what's 4 millimeters. You can measure it better on a CT scan. But I look at the lateral edge of the talus and see if it's in line with the lateral edge of the plafond. Mm-hmm. Here it looks shifted.
Yeah.
And even a millimeter or two. And so that I would be very cautious. And if someone is like, I'm still not sure, and I know this might be controversial, I don't get an MRI, because an MRI it's hard for me to interpret some of the acute injuries on an MRI.
Yep.
I'm lucky where if this patient is in my clinic, I get a weight-bearing CT scan, and they show both views in ours. So I compare the left to the right, and if that's how I know if it's wide or not.
Yep.
And I think for me that's better because this is suspicious for me. I don't know what the end result was here, but I would say that talus looks a little bit laterally subluxed in reference to plafond.
Well, that's kind of why I show it because I think I think that's an important point. I think Ed Haupt at Mayo Jacksonville, wrote up a paper on looking at that lateral shift and kind of just described it, or at least looked at it. I don't remember all the details of the study, but it was a nice study because there have been a couple of things beyond just medial clear space widening. Like amount of displacement on the lateral view as being a predictor of instability. And so it's not concrete, but it seems like it's gathering evidence to make sure you make the right decision. And it's not necessarily just one clear-cut number that you're looking at. It's looking at the whole picture. And these are the things you try to pick up over time as you treat a number of these. And then I put this together because we talk about trying to make a good decision for patients. And what is the influence? You mentioned this already a little bit on the utilization of using weight-bearing X-rays. So this idea of using weight-bearing X-rays, and this was just a little summary slide. And 2-year outcomes, and I guess some people may say we need like 10 or 15 to really know like what's the risk of arthritis in this case. But at least at 2 years, outcomes looking pretty similar between these two groups of patients. And basically what they did is they did a gravity stress, and those that had an unstable gravity stress but a stable weight-bearing X-ray. And this might get to the point I was making before, is that sometimes that gravity stress gets done with the foot a little bit plantar flex, and it artificially opens up that medial clear space. I wonder how much that plays a role in this particular study. Thoughts on this, Jan?
Yeah, I think it just shows like, we don't know everything, right, about these ankle fractures. We talked about the syndesmosis. The more we get to, I guess, study it, we have better imaging modalities. MRI, CT, very readily available in most parts of the United States and Europe, for example. And I think, like you said, many of these patients do well, at least short term. Mm-hmm. I do question still how they will do long term.
Yep.
And as long as I think the ankle becomes stable and heals in that position, that's fine. Okay, what if it doesn't? I think they didn't have anybody actually who fell off the treatment arm, but if you do have any shift, like we know that those patients don't do as well, right? Like that's of the talus, and what happens at 10, 15 years out, like you mentioned, so I think it depends on the patient, and I think, maybe if they're stable at 3 months, or, they still need to be checked, right? Yeah. I don't think it's one that I would discharge from my clinic, like, oh, your ankle's stable, call me in a year if there's a problem. I bring these patients back, non-op ankles that are, I would say like this, like a Weber B fibula. Mm-hmm. I bring them back to clinic more often in the beginning than my operative cases. Mm-hmm. Just to check on, make sure there's nothing shifting. And I know this study shows they really don't shift. I'm still very conscientious that they could.
I do the same, but here's the question. How often have you had to switch?
Never.
Yeah, same. I had one.
Everybody I talk to says never, but it's like somehow like maybe it's our medical legal climate,
Maybe.
But you're right. I have not had to shift. And like the only time I did was someone had a new injury. They fell again. Yep. Then it was like you didn't need a stress view. Basically, they dislocated it. And you're like, okay, well, that's obviously unstable. They went to the OR.
So then the question is, like, if you're concerned about it, let's just say, like, I think this is stable. Maybe it opens a little bit wide on the medial clear space, but the coverage was directly underneath the tibia like I want to see. They can do a weight-bearing exam. Are you putting any of these patients in casts, or are you doing boots?
Most of the time boots. Extremely rare for me to do a cast for that. Unless the patient is like, oh, I'm really worried. I talked about, like, hey, this could shift. Like, I always tell them, like, hey, we'll have to bring you back. Yeah. And they'll be like, what can I do to make it not shift? And I'm like, well, we want you to walk on it. We think it's stable. And if they get anxious and I'm getting anxious because of their anxiety, I put them in a cast.
That's fair. That's a good
probably to treat both of us, right?
Yeah.
And it treats me and them. What I'll do is like, well, let's just try a cast for 2 weeks. And then they come back and they're not in a, like, we take the cast off and they're not getting one back on. So
yeah. I think that's an excellent point.